Good morning to everyone for joining. So permit me to welcome you to this session of our AMR CoP webinar number 10. We will want to highlight that the translation services available. So if you want to get the French version or the English version, you should be able to switch between both languages. Just to highlight that our main interpreter, our main presenter today will be doing for us this presentation in French. So be ready to switch to the English channel to be able to get the translation. So today we'll be exploring a very important topic to look at the role of the biologist in the laboratory in the fight against AMR and AMR surveillance. We know that AMR surveillance is very key if we have to win the fight against antimicrobial resistance. And we know that we are working in the context of limited resources, and therefore, as the biologists within the laboratory, what is our role? How can we contribute to this fight? Our main topic for today is antibiogram and antibiotherapy, the role of the biologist in the laboratory. As our presenter for today, we have the honor to welcome Professor Hortense Gonsu. Professor Hortense Gonsu is a professor in the Department of Microbiology, Hematology, and Infectious Disease of the Faculty of Medicine of the University of Yaounde 1. She is head of the bacteriology laboratory of the University Teaching Hospital in Yaounde. She is the vice president of the Committee for the Control of Nosocomial Infection at the University Teaching Hospital. She is the national president of the Bioreagent Commission at the Ministry of Public Health, Cameroon. She is equally the member of the National Drug Committee. She is the president of the Cameroon Society for Microbiology, and she is the national consultant for USAID for the AWARE classification and the development of the antibiotic therapeutic guide for common bacterial infections. Before I hand the floor over to our presenter for today, our facilitator, I will wish to remind us of the availability of translation services. So you can switch between both languages, English and French, to get the interpretation. And also wish to remind that we should be able to send our questions using the chat box, our comment. Our colleagues, my colleagues who are currently in the background, will be able to provide some responses, and any additional responses we will present to Prof at the end of the presentation should be able to provide those additional responses. So me speaking, I have the honor, I am Sylvanus Fontekwe. So I'm a regional coordinator working with ASLM, and you are welcome to this ASLM CoP webinar number 10. Thank you. We will have the honor to welcome Professor Hortense Kamga Gonsu. Prof, you have the floor.
Merci beaucoup, Mr. Sylvanus. Thank you very much for giving me the floor. Cher ASLM team, je vous remercie pour cette sollicitation.
Dear ISLM team, I definitely thank you for this solicitation regarding the resistance to antimicrobial resistance, and thank you for your ongoing commitment to continuing education and the global scourge of antimicrobial resistance. And sorry for this technical problem. After a brief presentation, we will speak about the situation in the world, and especially in Africa, where our countries are limited in resources. The theme of this presentation is from what is the role of biologists regarding the antibiotic susceptibility testing to antibiotic therapy, the role of biologists in efficient surveillance and multi-drug resistance. So, as I said, the theme of this presentation is from antibiotic susceptibility testing to antibiotic surveillance, therapy. I believe the role of biologists in efficient surveillance and multi-drug resistance bacteria in resource-limited countries. We are going to look at the worldwide situation in Europe and especially in Africa with countries with limited resources. So what is the antimicrobial resistance? So it is definitely a threat regarding the worldwide health and also health security, food security. It is a natural phenomenon, but definitely also present for animals and human beings, accelerating this process. And if we are to combat this phenomenon effectively, we need to incorporate the concept of One Health. So it is a concept of One Health which requires multisectoral action to better manage infectious diseases. So to illustrate this multi-resistant bacteria, so in the past, we had some bacteria that were essentially nocosomial, for example, phenotypes of MRSA, methicillin-resistant Staphylococcus aureus, vancomycin-resistant, multi-resistant Pseudomonas aeruginosa, for example, multi-resistant Acinetobacteria, an extended spectrum beta-lactamase-producing Enterobacteria, and others. And what is happening today? Well, for this antibacteria, for still resistant to carbapenem, and we'll see this in our spread in our community, and many through the relaxation of infection prevention and control measures. Hospital hygiene, therefore, needs to be further strengthened as far as antibiotic resistance is concerned. So what is the situation in the world? So to illustrate this phenomenon, I can say that about 700,000 cases of deaths per year. And if nothing is done till 2050, there will be 10 million deaths attributable to antimicrobial resistance. And in Africa, mostly 4,150,000 cases, and also in Asia. So this phenomenon definitely concerns the virus and also parasites and also fungi, all categories of microbes. But we are going to speak about antibacterials. This is where the fight needs to be amplified. So the abusive consumption of antibiotics is definitely one, or the overuse of inappropriate use of antibiotics is one of the biggest factors encouraging the emergence of antimicrobial resistance. And we can see it in 5 countries with the highest antibiotic consumptions: Greece, France, Belgium, Italy, and Luxembourg. And in 2017, the main bacteria group pathogen of interest that we should be monitoring, as we can see. So we have the acronym ESCAPE, and ESCAPE is E for Enterococcus faecium, and the aim here is to search for vancomycin-resistant phenotype, vancomycin-resistant Enterococcus, and then you have the S for Staphylococcus aureus to search for MRSA, and then we have also the E for coli and Klebsiella, and A for Acetobacter baumannii, and P for Pseudomonas aeruginosa, and E for Enterobacter, and the first was E for Enterococcus faecium. So here is the acronym ESCAPE grouped together on this slide. As the phenomenon continues to grow, the WHO has revised the list since 2024, and we have the list of priority bacteria to monitor. This is the highest priority and the true critical priority, as we see. So the bacteria such as the carbapenem resistant baumannii acetobacteria and enterobacteria, and also I would say just E. coli, Klebsiella, enterobacteria resistant to third generation cephalosporin, which belong to the beta-lactam family and are the most commonly used antibiotics, and carbapenem resistant enterobacteria, which are seeing more and more in the figures are on the rise, with rifampin resistant Mycobacterium tuberculosis being one of the critical priorities. So as we know, though the list is longer, we have Salmonella typhi, which is responsible for typhoid fever, the resistance to fluoroquinolone, and Shigella, which is resistant to fluoroquinolone as well, and the one resistant to vancomycin, and for the group A, streptococci or pneumonia, streptococci usually called macrolide resistance, pneumocyon penicillin resistance to Haemophilus influenza, and streptococci penicillin resistance group B. So what is the situation in Africa? We talk about countries with limited resources in the African continent. So when we just look at some countries, we can see that the one with Enterobacteriaceae secreting broad spectrum beta-lactamase, and we see when we look at African country, the frequency of Enterobacteriaceae producing broad spectrum beta-lactamase is high and higher than 50% on average. So for example, in Kenya with 96.53%, and then we see if we look at E. coli, Klebsiella, especially pneumonia Klebsiella and methicillin resistant Staphylococcus aureus, these are three elements in the fight against multi-resistance bacteria. So far as E. coli is concerned, we can see that different regions of Africa are represented, and we can see that, and the rates are different. And we can see, we note that in West Africa, different regions are represented here. So we can see that the resistance to carbapenem is quite elevated compared to other regions in Africa. And regarding Staphylococcus aureus, we can see that it's rare, and so far as Klebsiella is concerned, it's almost the same. We can see that it's acceptable in South Africa, for example, but for everything else, rates are still high, and recent rates of Klebsiella remain high. So what about methicillin resistance Staphylococcus aureus? We look at vancomycin resistance, we can see it remains a rare phenomenon with the exception of East Africa, where vancomycin resistance is still somewhat high. After this brief review of antibiotic resistance, we are going to look at antibiotic susceptibility testing and antibiotic therapy. So this is what we want to talk about, isn't it? So what is this susceptibility? Well, antibiotic susceptibility testing is definitely enable us to determine the sensitivity of bacterium to various antibiotics, to one or more, of course. So what is the objective? So it is to predict the therapeutic success of failure. Antibiotic susceptibility testing is also of epidemiological interest because it enables us to monitor the development of antimicrobial resistance, and also to be used to up the treatment regimen based on a syndromic approach. And so also for the biologic is not enough just to report on sensitivities of resistance, but also to monitor the development of resistance. And we can use different methods for this. So you have the direct method and the indirect method. So for the, we need to determine the concentration and also it can be done, for example, direct method can help us to identify the minimum inhibitory concentrations. It can be manual, semi-automated, or fully automated. And also we can, for example, with the indirect method, measure variable parameters. For example, the inhibition diameter. This is known as the suggestive disk diffusion method, also known as the Kirby-Boa disk method. So when we get the results, it is done according to categories, according to the sensitivity of bacteria to antibiotics. So, for example, you have the S strain, which is the sensitivity. For example, when you have the minimum inhibitory concentration is less than the spherical concentration of the antibiotic obtained during treatment at the usual dosage. You have also the R strain. Here, the minimum inhibitory concentration is higher than the spherical concentration. And we also have, we mentioned the I strain for intermediate, but now the language has changed, so we we'll call it, for example, the high sensitive strain with high dosage. Regarding the antibiotherapy, now, so how can we interpret this and how can it definitely influence the antibiotic? So it means to prescribe the antibiotic to a patient. For example, the choice of discs for the resistance of phenotype. So for example, we have the disc which are the markers. So this is definitely enables us to interpret the susceptibility for salmonella, for example, and also we have the disposition of a disc. If you want to look for beta-lactamase resistant, for example, you need to arrange your disc in a certain manner to look for particular phenotype. For example, if you want to look at something for third generation cephalosporin, penicillin combined with an inhibitor it looks like a champagne cork. And you need also to put attention, should be paid to the load of the disc. And here is the biologist or the technician must be vigilant, because when discs are ordered if the loads are not checked, for example, there is a risk of underestimated or overestimating to the bacterial group attested, and it should be above all be based on the recommendation of a reference of antibiotic susceptibility testing and the usual reference, for example, the ECAST or CSFM for the CSLI, which is an American standard. So consequently, when reporting a result, it is important to avoid the pitfalls that can lead to incorrect prescribing. Apply the recommendation of up-to-date standards, and because in 2025, when you want to interpret an antibiotic susceptibility test, you can't just consult the reference from 2020. We need to make the necessary correction to ensure that antibiotic susceptibility test is correctly validated, because in antibiotic susceptibility tests, we can see that the diameter corresponds to a sensitivity, but when doing the interpretative reading, the biologist has the right to make the results resistant. In other words, report results by antibiotic family, because it makes it easier to read the report and indicate the resistance phenotype detected. And it's not easy, and it's not enough to interpret it. You need to give it a signification. For example, if you detected it and it is positive, you need to know if it is resistant to all beta-lactamine or to cephalosporin of third generation or fourth generation. So everything goes into this interpretation, for example. And also, for example, if it is also, the biologist has to say whether this bacterium, which produces an extended spectrum beta-lactamase, for example, is capable of being sensitive to third or fourth generation cephalosporin. For example, are we going to, will this bacterium be sensitive to other beta-lactamase? Do we need to do other tests, for example? Do we need to do confirmation PCR or other tests? And we need to explain it, and it's the role of the biologist to explain it to clinicians. So let's talk about another chapter, which is the key chapter of this presentation, which is the contribution of the biologist to antimicrobial resistance. So what is really the role of the biologist in the surveillance of antimicrobial resistance? So he plays a crucial role in the interpretation of, as he is also guarantees the reliance of these results. So it enables to identify, interpret the antibiogram resistance phenotypes, and also must reach out to clinicians so that the clinician can definitely choose the best antibiotic and the appropriate one. So in antibiotherapy, the biologist rule definitely has an important role to play, as we think that biologists must only be in the laboratory and validate results. No, it is definitely not the case. He plays a crucial role in monitoring AMR and in determining the effectiveness of treatments. So he also contributes to guiding and not imposing, of course, but by guiding the clinicians to the best adopted treatments regarding the obtained test results. So biologists should also organize meetings of clinical biologists, and it is a very important context as it will enable communication and collaboration with clinicians regarding the fight against AMR. And it is a collective fight or a collective battle, and it will definitely explain also the different approaches that the laboratory is proposing to put in place. To take an increasingly common example, we have the bacteria that are totally resistant to all antibiotics. If I take the GPPS, the global point prevalence survey, which is one one-off survey to assess antimicrobial prescribing practices, is carried out without multidisciplinary teams of clinicians and microbiologists. As a result, biology should also contribute to the revision of management of algorithm for infectious diseases, and even to the production of treatment guidelines, because treatment guidelines are not written primarily by clinicians. We need to obtain epidemiological data from the laboratories to be able to add to the guidelines. So what are the biologists' main responsibilities in interpreting antibiotic susceptibility tests? So not only validation of the technique and quality of the results, identification of the bacteria, interpretation, sensitivity, and integration of clinical and epidemiological data. So the responsibilities of the biologist, so what are they? So not only validation, of course, but also quality of data. As I've mentioned, again, identification of the bacteria. And it is definitely what he does usually, but then interpretation, sensitivity, integration of clinical, and it means that the biologic takes into account the clinical information provided by the doctor. For example, the type of infection, the site of the infection, the other patient data, so that they must be inserted into the antibiogram to take into context. For example, we need to know if it is an adult or a child, so that we can adapt it to or insert it in the antibiogram, and also takes into account the local epidemiology of bacterial resistance to adapt into the interpretation. And again, we should not exclude the technician. He should collaborate with the clinician and also give his recommendations.
Maintenant, pour le dernier point concerne dans la communication des
And
résultats aux
regarding
cliniciens.
how we communicate results to clinicians, so the biologist should do so in a clear and concise manner. And he can't use acronyms or abbreviations, for example, because clinicians will not understand them and the message will not get across. So the biologist must be clear in the way he communicates his results. And it may be also necessary that the biologist explain the results and answer the clinician's question about interpretation and the choice of antibiotic therapy. So as you see, the collaboration and communication with the clinician is extremely important. And regarding this subject, what is the role of the biologist, medical biologist, regarding surveillance of AMR? It is not only the interpreting the lecture and results, but how it can definitely convey and contribute to the surveillance. You have the routine surveillance, for example, and the passive surveillance. In a laboratory, for example, it will transfer the data and then it will definitely then go on and be transferred to the clinicians or to the ministry or department. The biologic in this role contribute to data analysis also, so that we can identify trends and risk factors, so that we can definitely evaluate the impact and prevention measures. So it should be done systematically, should be transferred to the directorate of each hospital or laboratory, and also to the hierarchy, so that we can understand what is happening in laboratoria, so that we can have preventive measures in place. And also, he participates in research and development, so they can also be, for example, involved in research projects to improve methods of detecting and monitoring multi-resistant bacteria. They also play an advisory and expert role and can advise clinicians on screening, treatment, and prevention strategy adapted to multi-resistant bacteria.
Donc, nous avons beaucoup insisté sur la
So
contribution
we
du
insisted
biologiste.
on the
C'était fait
contribution
exprès
of the
parce
biologist, and
que, on a
definitely
coutume
it
de
is
penser que le
important.
biologiste se
And
limite dans
we
ses
want
quatre
to
murs du
underline it.
laboratoire.
We
Non,
think
le
that the
biologiste,
biologist
c'est
is
vrai,
only
c'est lui
working
qui sert
between
de
the four
fondation,
walls of
c'est
his
sur lui qu'on s'appuie pour le
laboratory,
diagnostic,
but
mais
no,
il doit
definitely
pouvoir
not.
expliquer
No,
ce qu'il fait au
definitely not. I
laboratoire,
mean,
il
he
doit
must
pouvoir
be able to
transmettre ses
explain
données,
what he
il doit
does
pouvoir
in the
contribuer à la
laboratory and
discussion
to
sur la
contribute
prise
to
en
the
charge
discussion on
des
how to
patients,
treat
efficience des patients.
patients.
Donc, le biologiste
In other
va
words, the
sortir de sa
biologist
paillasse,
must
mettre la
definitely
contribution, son expertise
go
dans
out of his
l'orientation de
four walls
l'antibiothérapie
and be
et
able
la prise en
to
charge des
act in
pathologies
concert with
infectieuses de
clinicians and
concert,
play
bien
this
sûr,
role
avec les
as an
cliniciens.
expert in reading
Et
and
pour
interpreting
conclure,
antibiotic
le biologiste
suitability
est un
test, and a
acteur
role that is
clé
essential
dans le
for
processus de
ensuring the
diagnostic et de
antibiotic
prise en charge des
therapy
infections bactériennes.
and it is
Il
appropriate
joue
and
un rôle
effective in
d'expert
helping
dans la
combat
lecture et
the
l'interprétation des
bacterial
antibiogrammes,
resistance.
d'où la nécessité de faire
And it is
plusieurs formations dans nos
necessary
pays à
so
ressources limitées
to
sur
have
la lecture et
different
interprétative des
training in how to interpret antibiotic susceptibility, and it will definitely help to close the gap and to have a better communication with clinicians so that we can have an appropriate and effective antibiotherapy helping to fight bacterial resistance. So you will also see here three guides here on these slides. These are antibiotic therapy guides. The one on the left supported by CDC Africa. And in Africa, also, some countries decided to draft their own guide or a manual, and it is important to have your own guide to antibiotic therapy. For example, you have the one of the African Union on the left, supported by CDC Africa, regarding the antibiotic therapy for adults and children. Another example of an African country, for example, Togo, in the middle, they have a guide of antibiotic therapy for adults. And also in Cameroon, we have an antibiotic therapy guide for common bacterial pathologies, which are common in Cameroon. So here you also have guidelines that are most widely used in the world. For the standard one, it is the ECAST, as you can see, SFM, which is used by French-speaking countries. And we also have the CLSI, which is American and used mostly by Anglophone countries. So I hope that my presentation was interesting to you, and thank you very much for your attentive listening and kind attention.
Merci, merci infiniment, Prof, pour cette présentation. Merci pour la participation. Et je sais qu'il y a beaucoup de questions qui sont dans le chat box.
So there are many questions in the chat box, so we try to answer. Otherwise, for more questions, I would like to, we only have 9 minutes. I would like to thank you, Prof, for being so brief and concise with your presentation. So the first question in the chat box, the participant would like to know, and first of all, he says, thank you. Oh, there is a survey, a poll that we put on the screen to know your impression. How was this session? You can answer this poll. So the first question is to know, in Cameroon and Africa, what are the means and collect mechanism for data collection on AMR? So, Prof, can you please provide an answer to that? Yes, definitely. So are we going to collect all the question, or am I going to? Also, there are 5 questions. Let's ask all the questions. So second question, and then we will give answers. So after the 5 questions, I would like to why the syndromic surveillance is does prevail in the AMR, and otherwise on your slides number 6, when the BLSE is positive, what are we going
Et d'autres
to
questions?
do about it
L'usage des
regarding the
antibiotiques en
resistance?
traitement est
And
très répandu dans nos
if
contextes.
indeed in
Comment
the
pallier à
context
ce phénomène,
when
sachant que les résultats du
the
laboratoire
phenomenon
parlent à
is
la rigueur
there is
de
a
la culture à
widespread.
l'antibiogramme, avec des
So
méthodes
how can
indirectes très
we do
utilisées.
that with
Je pense
direct
que
and
c'est aux
indirect
dernières
method,
questions.
as you mentioned?
Pour le rôle de
And
biologiste, nous savons que le
regarding the
médecin se sent
biologist role, we know that
tout
clinicians
suffisant minimiser le rôle de biologiste. Quel
minimize the
faire
role
pour
of
une meilleure
biologists.
collaboration
So
afin de mieux
what do
lutter
we
contre
need
la
to do
rame?
to have a better
Bon, je pense que c'est ces questions
collaboration
que j'ai
with
retenues.
clinicians
Donc,
to
Prof, vous avez la
fight
parole.
against AMR?
Donc,
These were the
merci beaucoup
questions.
pour ces questions,
Thank you
Mr.
very
Sylvanus. Vous
much
imaginez que je n'ai pas pu
for
relever
these
toutes les questions,
questions.
donc
Definitely, I couldn't
je
write all the questions
vais
as
de
you
temps
imagined,
en
but I'm
temps
going
vous
to
demander de
try to
repréciser la
respond,
question.
and maybe I will
Bon,
ask you
pour
to
la
repeat the
toute
question if
première,
necessary.
je
Regarding
pense
your
que le
first
participant
question,
voulait
I
savoir
believe
quels
that
sont les
the
moyens de lutte,
participants
de
wanted to
collecte.
know
Quels sont
what
les
are
moyens de collecte
the
des données
means of
et comment est-ce que
collecting
ces données
data
sont
and
remontées
how this data
dans le système de
can
surveillance de la RAM,
be
je pense.
inserted in
Exactement,
the
oui, c'est ça.
oversight system of
Voilà.
Selon
AMR.
l'approche une santé.
Definitely. So
Selon
for the
l'approche
One
Une
Health.
Santé.
Oh, regarding
Très
the
bien.
One Health approach.
Donc, en
Okay.
fait, le Cameroun
So in
ayant intégré le
Cameroon,
GLAS,
we
qui est le
definitely
le Global
integrated the GLOS, the Global
Surveillance Survey.
Antimicrobial
Donc, c'est un
Resistant
programme
Surveillance
de l'OMS.
Survey. It is a program of WHO, and
ce
we
programme et il
integrated
était
this
donc question
program.
que nous puissions
And
surveiller les bactéries
we
multirésistantes.
wanted
Et
to
un
have
plan
a better
d'action
oversight of
national avait été
multi-resistant
élaboré,
resistant
le premier plan
bacteria
de
at national
2018
level.
à
And
2020,
after the
et
plan
ceci
of
a permis de pouvoir
2018 to
identifier
2020,
quelques sites
we did
sentinelles
it already. We
avec lesquels le
integrated
ministère de la
and
Santé
we
publique allait commencer la
identified
surveillance.
the
Donc, au départ, il y
sites
avait
that
8
could
sites
start with
sentinelles. Et
oversight.
pour
So
répondre
we
à l'approche
had
One Health, parmi les 8
8
sites sentinelles, il y avait
sentinel sites,
6 sites
and
en
we
secteur humain,
had
santé
6
humaine,
in
et il y avait
human
2
health
sites
and
dans le
2
secteur de la santé animale.
regarding
Le
animal
secteur de la
health.
santé environnementale
For
n'étant pas encore assez développé,
environmental
n'ayant pas des
health
laboratoires
was not
nationaux,
really developed, and we didn't
le
have
ministère
national
n'a
laboratories
pas pu
yet,
les
so the
intégrer. Donc,
ministry
pour
could
l'instant,
not
voilà les 2
integrate
secteurs
these.
qui sont fonctionnels.
For the
Et au
moment,
jour
these are the
d'aujourd'hui, nous sommes,
2
si je ne me
functional
trompe, à
sectors,
23
and
sites
we have
qui
now
participent au programme de
23
surveillance
sites
de la
that
résistance aux
participate
antimicrobiens.
in
Nous
the
sommes donc partis
oversight
de
program of
8 sites à
AMR.
23 sites.
So we
Et
went
parmi
from
même
8
les 23
to
sites, il y a eu
23.
d'autres sites encore dans le
And there
secteur
are other
animal.
sites
Et
in
ces
the
données
animal
qui sont
sectors,
collectées, il
and
y a eu des
these
formations,
data that are
des
connected
points
to definitely
focaux de ces sites.
collected. We
Et ces points focaux étaient chargés
have
d'aller
6
répercuter le
focal
système
points
de
that
surveillance
were in
harmonisé.
charge
Et lorsque
to
nous collectons les données
harmonize
de
this
façon
oversight
mensuelle,
system,
ces
and
données vont
we
être
do that on
transmises au
monthly
laboratoire national de santé publique,
at
qui est le
monthly
laboratoire qui
every
coordonne
month.
cette
And
activité de One Health.
there is
Donc, les
also
données sont remontées
the
et le
laboratory
laboratoire
that
national de santé
coordinates
publique va
the
donc
One
de façon
Health
parallèle transmettre les
activity.
données aux différentes
For
directions
we
des ministères, que
definitely
ce soit au
collect it, and
ministère
we
de
can
l'élevage ou
thereafter
bien au
transfer
ministère
the
de la santé
data
publique.
to a different
Donc, et ensuite,
department or
ces données
ministry, the health
devraient
minister
remonter
or the
à l'OMS
ministry of
puisqu'on fait partie de ce programme.
husbandry
Donc,
or
voilà
the
comment
ministry of public
dans la
health.
pyramide, les données
So
partent
this
des
is how
laboratoires
in
qui
this
sont des sites sentinelles et se
pyramid
retrouvent
the
donc
data
dans les
that we
ministères
collect
et voire même à l'OMS.
in the field
Je ne sais
can
pas si j'ai
reach
pu.
the
Donc, il y a cette intégration
ministry
de One
and
Health
also
et le secteur
WHO. I don't know
santé
if I
environnementale
responded
va être
to
développé
other
d'un moment à
question, and
l'autre.
also
Déjà, ils sont
the
même déjà dans la
environmental
logique
sector
de
will
pouvoir
be
participer à
developed
cette
very
surveillance. Je
soon
pense que c'est des
so
problèmes
that we
techniques,
can have a
si je
better
me trompe,
oversight.
qui vont être
And
résolus d'ici
I
peu
believe
et je
that there
pense qu'ils
were
vont
some
intégrer
technical
aussi
problem. I
ce
believe that
système.
they will
D'ailleurs,
be
même pour
very soon
élaborer ce guide,
integrated.
il y avait des
And
points focaux
we also had focal points
des points focaux du ministère de l'Environnement.
Of the Ministry of
Merci,
Environment.
Prof.
Thank you, Prof. Regarding your second question, the participant wanted to know why the syndromic surveillance is privileged in the ARM. Regarding AMR, we don't, not everyone does the the antibiotic susceptibility testing. So we have integrated health centers, we have CMAs that are not habilitated to do this susceptibility testing. So we, the syndromic approach helps clinicians and takes in consideration the microbial epidemiology in our countries. So instead of not knowing where we go and to grope, definitely it helps the clinicians to treat patients affected by infectious pathologies. So, Prof, we only have 2 minutes before the end of the session. I will definitely share the questions with you, Prof, and you will respond to them, and it will be available on the website of ASLM. So the ECHO webinar, you will have this presentation and the responses to the questions. We also will integrate it in this website. Everything will be on the website.
I think,
and
just to go back to English to thank everybody and thank all our presenter, Professor Hortense Gonsu, for your time and for your dedication and for the work that you do when it comes to AMR, when it comes to bacteriology and all your contribution nationally and internationally. So we want to thank all the participants from where you're joining. From wherever you're joining, from your lab, from your workspace, thank you for your time. I want to thank all the collaborators who are working behind the scene to see that this session was successful. And we want to thank you once more for being very, very, very attentive. The number of questions that we have received shows that the participants were actually listening and that it was exciting. The polls are still ongoing, so we thank you for responding. So we would like to say at this point in time, we would like to end here, and maybe you want to invite Prof for any last words that you want to give to your participant. Prof?
Merci beaucoup, Mr. Sylvanus.
Thank you so much, Mr. Sylvanus. I would like briefly thank you again and thank you to the participants. And on this note, definitely the biologist must valorize himself. So if the clinician doesn't take you in consideration, it's because maybe we don't give enough value, enough credit to ourselves. And we are not here only to sign the results. We are here to participate in the fight against certain infectious pathologies, or to definitely ring the alarm when something is multi-resistant and bacteria are multi-resistant, definitely. So this is our role. There is no question to that. Thank you.
Thank you so much, Prof. Thank you for participating. Thank you for your time, and see you in the fortnight for our next session on AMR CoP webinar. Thank you so much and goodbye.